Hello, everyone, and thank you so much for joining us today for Coffee Talks. Today's topic is entitled Missed Opportunities. Presenting with me today, we have Carissa Little, our account manager, Colleen Cusack, our client services specialist, Kristen Moore from Union Hospital, and myself, Kia Beth Santos, the newborn team supervisor. Kristen, if you can please introduce yourself to our audience.
Hi, everybody. My name is Kristen Moore. I'm the Director of Maternal Child Services at Union Hospital in Terre Haute, Indiana.
Thank you. So the team in front of you today works with hospitals all across the country to improve their newborn drug testing programs. If you are new with us today, let me tell you a little bit of what Coffee Talks is. Coffee Talks is where we meet once a quarter to discuss contemporary topics in newborn toxicology. We have partnered with many hospitals throughout the United States to provide newborn drug testing services. And as such, we continue to stay current with the challenges as well as with what is working.
Kristen, we are so excited to have you here today with us as a guest speaker, and we would like to thank you that you take this time out to join us today. So thank you so much. So before we begin, let's start with the housekeeping rules. Please submit any questions that you may have in the Q&A section at any time during the session. At the end of the session, we will open up the platform to answer any questions that you may have submitted. Now, I know that there's a lot of information that will be given out today, so we'll be sending a recording to attendees to view for future use. We'll be also sending copies of the articles mentioned in PDF format as well. Now that we are done, I will pass it off to Kiva to jump right into our great discussion today.
Thank you for that, Carissa. So as mentioned earlier, today's topic is entitled Missed Opportunities. So for today's agenda, we will discuss common problems found within the newborn drug testing realm. We're going to ask our guest speakers questions so they can go ahead and share their insight and provide a solution to combat the problems discussed. So let's begin with the common challenges found within the newborn drug testing realm. So a common challenge is not having a viable test available, which we hear a lot in the field. So how are ways that we can have a specimen not available? An example could be discarded by mother. So oftentimes, if a mother finds out that the neonate's meconium will be tested, she usually goes, grabs the diaper and discards it, and that can yield some missed opportunities. The ideal collection of meconium requires collecting the meconium from beginning until it has been excreted to get the maximum sensitivity look-back window. And if some of the diaper is discarded with some of the meconium, of course, that's some missed opportunities because you're not grabbing the full look-back window. Another example of a missed opportunity that we have discovered is the meconium lost during birth. So oftentimes, due to maternal stress factors, the meconium could be lost in utero. And again, that yields a missed opportunity. Another example is quantity not being sufficient. So it's not enough specimen to test. And this is oftentimes found in premature babies that were experienced in utero drug exposure. The preemies simply don't produce enough meconium, so that can yield a missed opportunity. Another example is a transfer baby. So when we're looking at transfer babies, sometimes, let's say if a neonate was released from one hospital to the other, the neonate can still be in the transitional phase, releasing some of the meconium. But again, the hospital can grab some of the meconium, but if some of that is missed, they're missing the opportunity because, as mentioned earlier, the ideal collection of meconium requires collection of the entire passage from beginning to end because the drugs are not scattered uniformly. And sometimes another example is with the transfer baby, if the meconium was missed, the umbilical cord tissue segment was not collected. So missed opportunity again. Now let's talk about problem with urine specimens. When we're looking at urine specimens, I hear from the fields all the time how difficult it is to collect their very first void. And it has just such a short window of detection. And this specimen has overall significant limitations. Most neonates produce very little urine in the very first few days of life, and it can be nearly impossible to collect an adequate amount of specimens. Another example of problems that is experienced in the field is criteria do not catch exposure. So either the hospital has no criteria in place for newborn drug testing, or they're relying solely on self-report from mom. And as we know, self-report is oftentimes unreliable due to the stigma that's out there and the moms being afraid that they're going to be judged. Or the hospital has a limited criteria for testing, so they're able to catch some of the neonates that were exposed to in utero drug exposure, but it's limited and it's not expanded enough, so there is room for advancing their policy and procedures. So these are also examples of missed opportunities. Another example is false negatives due to cutoff levels. So on the screen, you can see a letter to the editor that we wrote to JPEDS, and this article can actually be made available for you post this webinar, so please feel free to ask us. We will share a chart that we responded back to the letter of the editor. As you can see on the screen, sometimes the field can receive a false negative result due to high cutoff levels. As you can see on the lower left-hand side, it displays limits of detection. Our cutoff levels in some cases are significantly lower than those in some commercially available reference labs in the study. It's important to be mindful of cutoff levels because if they're high, it can yield a missed opportunity. And as you can see here, USDTL's cutoff levels are fairly low and very competitive in the industry. So everyone, we have gone over some of the common problems our healthcare professionals are experiencing within the newborn drug testing realm. At this time, I would like to open up the platform to ask you your feedback. If you can let us know if you've ever experienced any of these issues in your hospital within the past year, if you can please answer yes or no. So while we are waiting for our lovely audience to answer the question, Kristen, now I went through a lot of problems discussed. What are your thoughts on what I touched base on?
I think that I clinically at the bedside and now in leadership have experienced every single one of the things that you mentioned. They do present a problem. And I think that a lot of those missed opportunities, they result in a lack of detection of infants that might experience NAS and sometimes babies and families falling through the cracks. So I'm familiar with literally every single point that you spoke about. They all happen commonly.
Thank you so much for that, Kristen. We'll still give it some time to let our audience answer some of these polls. So Carissa, if you can take the lead from here.
Yes, absolutely. Colleen, let's start off with some questions. Can you share a story when a umbilical cord tissue and meconium was not available from a client, and what were those challenges?
You know, Carissa, this happens pretty often when a nurse calls in after attempting the very first collection of meconium. It already turns into stool, and then the meconium is no longer an option for testing. And I hear a lot of these concerns as this is never really the first time they're experiencing these challenges when collecting meconium. And so they're already kind of thinking of what the possible solution would be. And typically these conversations, they bring up possibly sending in the U cord to our to test here that they already have stored at their hospital. And this is some really good thinking. However, based on my experience, when the cord at the hospital is stored, when it's not their initial focus, it's stored into formalin, and that can affect the outcome of the drug testing results. So yeah, this is just really so challenging because now there's really no available matrix for testing, and this newborn is potentially at risk.
So much, Colleen. Kristen, what are your thoughts of what Colleen had said on not having a specimen available in your unit?
So I have to say that I work for a hospital. I don't work for USDTL. And I think that when I talk about our new process here at my hospital of umbilical cord testing, I sound like I work for USDTL. So disclaimer, I've not been paid to say anything that I'm saying. Our hospital started the process of umbilical cord collection back on November 1st of 2020. Prior to that, we utilized meconium and urine. And like it's been mentioned, when we utilized meconium and urine, first of all, it's just messy. Scraping meconium out of diapers is just, it's cumbersome. It takes a fair amount of time. You're relying on catching the meconium in the first place. So if the baby's had a meconium stool in utero, or if we miss, trying to get a urine bag on an infant is difficult. And I can tell you there have been so many times when at the bedside, you think you've got this urine bag on right, you walk in then later to check on the baby and the diaper's wet, or it's leaked around the bag. It's unreliable and it's difficult. And in those times prior to us collecting umbilical cords, what we would do is throw away the placenta and throw away the umbilical cord, just toss it. Or if we were saving it for, some reason we were testing the placenta, it was in formalin. And then you have no opportunity to do any testing on the baby. So starting in November, what we've found, now that we've changed over to umbilical cord sampling and testing, there's not been a single time since November 1st that we've experienced any of the missed opportunities that you're talking about. And the only one that I could think of that could potentially happen would be an outborn infant. So an infant born at another facility, or maybe born at home, and that's the missed opportunity, unless the baby comes in with enough cord still attached, or by some odd chance we have the placenta. We usually don't if it's a baby transferred in, but those would be the only missed opportunities that we now experience here at our hospital.
Sorry about that. My was just going on and off. But yes, thank you so much for that, Kristen. And also to add on to that, what happens in the NICU if you do not have a viable specimen to test?
So what happened prior to this is the baby just wouldn't be tested. If we didn't know at the time of delivery that the mom and the baby met criteria for testing, then we would have either missed the first urine or missed some meconium. And if the baby then later ended up in the NICU, we just wouldn't really know unless the mom honestly admitted what substances the baby may have been exposed to. We simply wouldn't have known. Now that never happens because we do 100% cord collection. That doesn't mean that we send 100% of the cords that we collect, but every baby that delivers here in our hospital, we collect a segment of cord, milk the blood, rinse it off, stick it in the specimen cup, and we save it in a refrigerator. So we send those cords for testing on infants that fit a certain criteria, things like mom not receiving prenatal care, insufficient prenatal care, a history of substance use. So if mom fits the criteria, we automatically send the cord. If mom does not, and later on we sense a reason, or we find out that in fact the mom and baby fit the criteria, or sometimes we have a baby that frankly we just didn't expect it, but the baby starts to show signs and symptoms of NAS, we always have the cord. So every baby that is in our NICU that has born in our hospital, we have that cord segment for 3 weeks after the delivery that we can send at any time. So prior to cord collection, what would happen is nothing. We'd have a baby potentially experiencing NAS and we wouldn't necessarily know what substances were in their system. Now, it just doesn't happen because every baby in our NICU, we have a cord sample for that we could send for testing if we needed to.
Thank you so much, Kristen. And that was an awesome explanation. So Colleen, I do have a question for you. What frustration have you seen clients experience with specimen rejections?
Well, honestly, when it comes to any irreplaceable newborn specimen, there can be many frustrations anytime those full final results are not fully completed. So let me give you guys an example. When a nurse calls in looking for the status of a meconium specimen and that final result was rejected due to QNS, this now means that they don't have that ability to see those full final results showing the breakdown of positive or negative. So at this moment, the nurse expresses to me that she's very frazzled, very stressed, and trying to figure out really what the next steps are to inform all the people from the doctors, social workers, to the parents of the newborn. And I'm really sure that this list really can go on and on, as many times when this type of conversation is happening, the newborn may already be experiencing withdrawals or is being held at the hospital as those next steps are being determined. And this can really be super stressful for anyone. And you can really tell when they're calling in with that stress. So, you know, there are two things that I know of that can really help reduce that stress and frustration when it comes to rejections. And the first thing would be to make sure that those proper collection protocols are being followed. And the second thing is what we're talking about, standard collections.
Thank you so much for that, Colleen. I see the answers that came through the poll, and I am not surprised by the poll answers, everyone. 77% of our audience mentioned they have experienced the problems we discussed earlier. So I am confident our solution coming up soon is going to be very helpful for you. So Kristen, we have a question for you. What challenges did you see with meconium and urine when you look back?
So I mentioned some of them earlier. First of all, it's just messy. Trying to get a urine bag on a baby is difficult. And just when you think you've got it, you don't. So there were frequent times that we missed the real first urine sample on a baby. Oftentimes babies deliver in the process of urinating. You deliver the baby, place the baby right on mama's chest, and babies often void right then and there at that moment. You don't even have time to get the urine bag on yet. Same thing with meconium. Babies can pass meconium in utero, so you've lost that bit of the sample. And just continuously collecting meconium until the baby stops passing meconium, it's cumbersome. It's time consuming. It's scraping out of a diaper with a tongue depressor and putting it into a it's just messy. It's messy. And so a lot of missed opportunities, a lot of lost samples. With the cord collection, it takes approximately 60 seconds. Messy, I suppose, because it's a little bit of a cord. You've got to milk the blood out and rinse it off, but we do it right on the delivery table. It's fast, it's simple. My staff absolutely loves it, most specifically the nurses that were trying to collect meconium for up to 24 to 30 hours after delivery. So meconium and urine collection, messy. They took a long time. They were cumbersome. It just didn't work as well as cord collection does.
Thank you so much for that, Kristen. You know, when I speak to the field, be it via the phone or when we're at conferences and they come say hello, they always say, oh, umbilical cord tissue drug testing. And then they comment, we do not miss collecting meconium passage. Nope, we don't. So another question here for you, Kristen. How did the hospital come up with their criteria for testing and how is it going now?
So we had already had some criteria that we utilized for sending off meconium and urine. We started with that, and then Kia Beth, when we started talks with USDTL, you had several example policies. So we sat down as a team, a nursing team, a leadership team, of course, engaged our physician staff, and laid out all the criteria and said, okay, what do we want our criteria to be? So it was actually pretty simple. Like I said, we already had some criteria. We just built on it a little bit. And what was the second part of the question? How's it going now? Wonderfully. I'm trying to think of barriers since we started in November, and I can't think of one. The process of setup was easy, educating our staff was easy, and I think we're going to talk about that in just a bit. It truly, everyone loves that we do this because we don't miss samples and it's easier. It's easier, it's faster, and we don't miss anybody. We get the results faster too. I don't know if I mentioned that, but the previous process that we utilized with meconium results for us, we're taking on average 11 to 12 days to return. The longest sample, I tracked them back for about a year and a half, had taken us 27 days to get the meconium result back. I think that the longest now with a cord has been maybe just over 72 hours. We almost always have negative cord results within 24 hours, and we almost always have positive cord results within 48. So we're not sending babies home without knowing the result of their umbilical cord testing, which is a huge relief.
Yes, I agree. And thank you so much, Kristen. And also, wanted to add one more question. Do you think there's a set criteria that can be 100% effective?
100% no. I think there's always going to be a patient who falls through the cracks. If you wanted 100% criteria for catching 100% of the babies, you would need to not only collect 100% of the cords, but you'd need to send 100% of the cords, which is frankly just too costly. And I think it would be unlikely for that to be supported unless you were maybe in a research project or something. So I don't think it's really possible to catch them 100% of the time, but I feel pretty confident that we're catching most.
Thank you so much, Kristen. I could imagine the peace it gives within you and your staff, knowing that you're doing everything you can possible to detect as many neonates as possible during this troubling time. All right, everyone. So now that we have discussed the problems in newborn drug testing, let's dive into our recommended solution. Our recommended solution to combat the problems we discussed is standardized collection. But before we begin with standardized collection, I would like to provide you a brief history about umbilical cord tissue drug testing. So umbilical cord tissue drug testing was developed by USDTL back in 2007. We're the first lab to launch this test. And when we developed umbilical cord tissue drug testing, it was with the goal to ease the collection process for our clients, improve overall turnaround time, and just make everyone happier. When hospitals initially began with umbilical cord tissue drug testing, they started off with targeted collection. Now you may ask, what does targeted collection look like? That's simply collecting umbilical cord tissue specimens only if the neonate meets criteria at birth and sending it off. If it didn't meet criteria, the umbilical cord tissue segment would just be discarded. So I had the pleasure of partnering with the Perinatal Quality Improvement Collaborative to work with their newborn pilot program back in 2015, which since then has evolved into the Indiana Perinatal Substance Use Hospital Initiative, which is still ongoing today. And partnering with this organization, they had a strong belief that it was so important to collect umbilical cord tissue segments on every baby, sending to us the ones that meet my criteria, of course. And it was basically just to ensure that no baby slipped through the cracks. And since they started developing this within Indiana, it pretty much set the foundation of how these segments should be collected moving forward. And since then, USDTL has been striving to educate the field on this type of collection. So standardized collection took a big step forward, again, as mentioned with the Indiana PSU initiative. And since then, many hospitals have transitioned to this method of collection to ensure there is no missed opportunity. So with that, Carissa, can you please share with the audience how standardized collection looks like?
Yes, absolutely. As far as the standardized collection, the formal definition is the act of collecting cord tissue on every neonate and sending the one that meets criteria. As being the educator for the hospital staff, they have stated that the process has been fairly easy and an efficient process. You will first collect a 6-inch segment of the cord tissue and place it into the specimen container. If a neonate meets criteria at birth, you will send it to our lab for testing. Now, if the neonate does not meet criteria, you will store that specimen, and should the neonate show any symptoms or onsets of withdrawals hours or days later, you can then send it to our lab for testing.
Thank you, Carissa. You know, Carissa, when hospitals hear collecting cords on every neonate, they feel it sounds daunting when it really is not, based off of the field's feedback. Can you share with us some visuals of how much room hospital staff use when storing the umbilical cord tissue segments?
Yes, I will share some visuals for the audience today. Here popping up on the screen, you will see some storage options. So here on the left is for a small birthing hospital. And to say you need to store a maximum, let's say about 50 specimens a week. As you can see, you're hardly not using any space at all. Now here on the left is for a birthing hospital, to say you're a busy hospital with 100 births a week. Even at 200 specimens, you really don't require a great deal of space either to store these specimens. So yes, these are the visuals for the storage options for cord specimens.
Thank you so much for sharing that, Carissa. Kristen, how long does your hospital store your umbilical cord segments at Union Hospital?
So we keep our segments refrigerated, and so we store them for 21 days after the birth of the baby. You're going to have to chime in, Kia Beth. I think unrefrigerated, they're good for 14 days, but we store ours for 21.
Yes, they're good refrigerated. It's good room temperature, 1 week, 3 weeks refrigerated, and 1 year frozen. So with that, Colleen, I do have a question for you. With your client-facing conversations, I understand that sometimes clients call you because they are unaware of how long they can keep cords. This basically is piggybacking off of what Kristen just mentioned, but can you chime in this again?
Yeah, so it's 1 week at room temperature. It is 3 weeks being refrigerated and up to 1 year being frozen. I was
Thank
like,
you.
oops.
Thank you so much, Colleen, for that, for reiterating the stability for the cord tissue. So Kristen, why did Union Hospital choose standardized collection?
Again, I'm not being paid by USDTL to say this, but I honestly, I couldn't see a reason not to. The cost was minimal. We had to purchase the refrigerator that we store the cords in, and then the specimen cups that we use to store them. But that cost, again, was very minimal compared to the results coming through faster and having the ability to test any baby that we wanted at any time. And then the reduced time that it takes for staff to complete the collection. We just could not see a reason to not collect every single cord. Even collecting every cord takes less time than collecting the select number of meconiums that we were collecting previously. And just having the ability to test any infant, should they show any signs or symptoms, or should we have any reason to suspect after delivery. Not having any missed opportunities at all was the reason that we chose to do universal standardized collection. And I don't regret it for a second. I don't know why anybody wouldn't.
If you can describe your hospital's onboarding experience and how this collection process is going for you all today.
Sure. So I actually have some experience from several years ago, about 5 or 6 years ago, at a different hospital that was part of the pilot program that you spoke about, Kia Beth. And even when we implemented cord collection and testing at that hospital, it was a pretty simple onboarding process. But because I have the experience from then until now, I can tell you it's even more simple. So when we onboarded Kia Beth this time around, you already had sample policies. And so it was so easy to just take all those policies and smush them into what worked for us. You also provided different printouts and all kinds of different resources for our staff, and pictures and step-by-step instructions that we just pulled together and we put them into a binder. And then additionally, Carissa did training for all of our staff, which when we thought, oh my gosh, now we have to do this, all the staff has to be trained. It was maybe 15 minutes, 10 to 15 minutes. Carissa joined us on a virtual platform, which nobody loves COVID, but it is something that has come out of COVID that is not a terrible thing. We do a lot of things virtually now. We held a department-wide meeting. Carissa participated in 2 of them in 1 week. All of our staff joined. 10, 15 minutes later, everybody had been educated. And then we offered the binder out to our staff. And then on day 1, when we went live, myself and our manager were just present to to answer any questions. We had a couple of kind of super users, but once you see it once, you realize, oh my gosh, this is so easy. So onboarding was pretty simple. I think that USDTL has so many resources now after having done it for so long that you basically offered them all, and there was, other than just implementing it, there wasn't a ton of extra work on our part.
Thank you so much for that, Kristen. And that is our ultimate goal, to make it as seamless as possible for our clients. I'm glad your experience was just that. So we have a final question for you, Kristen. What does it mean to the perinatal team to have a system in place that helps ensure none of these babies are slipping through the cracks?
So I think the idea of what it could mean to our team is how I quote unquote sold it to everybody, sold it to leadership and administration and our physician team. When I compared umbilical cord testing side by side with what our then current process was of utilizing meconium and urine, I talked about turnaround times. I talked about the number of patients that we did have. I started to track the number of patients that did slip through the cracks, and talked about the number of infants that we were sending home, not knowing, not having a result. And as nurses and physicians and case management is a huge player for us, because they had a very hard time sending babies home that they were fearful might be at risk for NAS without really knowing. And so now the relief that we have sending these babies out into the community and home with their families, or potentially maybe not doing that, I can't, it's hard to describe. I think that the biggest cheerleader for this is probably our case manager, our social worker, who is a deeply feeling person. And I think it's just offered us the peace of mind that we are able to care for our patient population in a more meaningful manner. I think that sometimes there's a misconception that the goal of drug testing, either maternal drug testing or newborn drug testing, that the goal of it is to take a baby away from its family. And that, in fact, is absolutely not our goal. Our goal, ideally, is to identify mothers in need prenatally so that we can lead them to help, and so that we can prepare them for the experience that they're going to have and the experience their infant is potentially going to have. And then the goal after delivery is to make sure that we care for the baby in the way that the baby needs to be cared for. An NAS baby it's a sensitive little one. And so our ability to identify that population, care for them appropriately, and have the peace of mind that we're doing the right thing, everyone loves it. Again, I'm not getting paid by USDTL, but it truly, it's just meaningful. It's meaningful for our team. And when I brought it up and again compared everything by side, for us, it was a no-brainer.
Wow, thank you so much, Kristen. And that was very thought-provoking, and hopefully for the audience as well. And I couldn't agree with you more. So with this discussion, it has been amazing thus far. I would like to thank Kristen and Colleen. Thank you so much for providing us much insight on this problem and solutions found within the newborn drug testing realm. We have learned a lot today. So to summarize it all up, there are many variables involved with having missed opportunities with being unable to test neonates in utero drug exposure. Although there are challenges with having viable specimen, there is a solution to prevent these obstacles, which was discussed today, and that is standardized collection. So standardized collection is collecting cord tissue on every neonate and sending that specimen that meets criteria. And the one that does not meet criteria, you can save as a fail-safe option. This gives you the security that you will always have a specimen available and to assure that the neonate is not slipping through the cracks. So now that we have summarized our great discussion today, Kia-Beth, can you open up the platform to the audience to answer some questions?
Absolutely. So we have some great questions that came through. So the first question that I see here is, after a substance is ingested, how long will it take for the cord tissue to test positive? So looking at this question, I think I can answer this one. After a specimen is ingested, how long will it take for the cord tissue to test positive? So here at USDTL, our turnaround time is the next business day for negatives. Anything that undergoes additional testing, that can take an additional 2 business days. And as far as how back does the umbilical cord tissue segment go, it goes back up to the last 20 weeks of pregnancy. There's another question that came through. I have experience with patients who actively use polysubstance IV throughout the entire pregnancy, and her cord came back negative. I know the test is not definitive, but does a negative cord stat indicate no risk for NAS? Colleen, would you want to answer this question, or you want me to go ahead? Okay. I'll go ahead. So with this question, I would say that if mom was using throughout the entire pregnancy and you see that it came back negative, the first thing I would encourage is to see what panel were you testing on mom. I'm sorry, on the neonate. Oftentimes, let's say if the mom was using gabapentin, but you're not testing for gabapentin, if you're not testing for it, it's not going to come out. Same thing for any other drug. So I would keep that in mind. And again, a negative result does not refute that mom did not use. If you ever have any sort of questions, concerns, I encourage you to please reach out to our toxicologist department. That's what they're here for. They provide a great wealth of information and get very science with you and technical and can answer any of your questions. If you get a result and you're confused of the quantitation levels, anything around that realm, call our customer service department. They are highly trained with toxicology support. And of course, if it's anything that they're not able to answer, they will connect you directly with a toxicologist.
Beth, do you care if I chime in for a minute?
Oh, go ahead.
I think that we've tested since November. I think it's over 130 samples. And I actually have experience with exactly what you're talking about. There was one cord that came through that the mom freely admitted substance use, and the cord came back negative. And so we were really suspicious, did we have the right result? There are cutoffs, every laboratory, whether you use meconium, whether you use urine, whether you use umbilical cords, there have to be cutoffs that are going to trigger the positive. And from my own research, USDTL has some of the lowest cutoffs you can find. So I think it'll be hard to find a laboratory that has lower cutoffs that would detect something or trigger a positive that USDTL wouldn't. But the one scenario when we had an admitting mother and we knew this infant was going through NAS. We contacted your team and you put us in touch with Dr. I'm so sorry, I can't remember his name. But he was very responsive and he asked very specifically, can you tell me specifically the substances that mom has admitted to using? And they were ones that we were testing for. And he said, let me get back to the specimen. And there is a chance that, that we detected, it just didn't hit the cutoff level. And he was able to come back with us and tell us the specific substance that, yes, it was kind of detected, but it didn't meet the cutoff level. So they suspected it was probably there, but because the level wasn't quite high enough, it didn't report out as positive. So we were able to discuss that as a team. And I think that we got that done within about 4 hours of contacting you. So I think there's always a chance that that's going to happen, but I would encourage people, if you have an admitting mother and the cord has come back negative, always reach out, because they were, and again, it did get a little bit technical, it was a little above my head, language that I don't necessarily speak, but he was really great at explaining it.
Thank you so much for that, Kristen. I have here another question. It says, Kristen, is there any advice that you have for hospitals when discussing this testing with a caseworker?
Yeah, I'm not sure if that question is about like trying to convince the caseworker that this is the way to go, or gosh, I don't know if maybe they're talking about a DCS caseworker. I'm going to go with thinking, and whoever asked the question, if you want to chat in and clarify a little bit, our caseworker here at our hospital, our social worker that helps coordinate care and resources for families, that person actually has access to our results. And so myself, our nursing care managers, and then our social worker, our case manager, we are all actively talking about any cases where we're sending a cord out and actively looking for the results to come back. And so I talk to our caseworker almost every single day, and they help coordinate resources on these moms that we are testing. They're the ones that have the conversation to let the mom know that we are sending the cord out for testing. And they're also the ones that help present the conversation to the mothers when the newborn does come back positive and the next steps that are going to be taken. So that's the hospital side of the caseworker. If you're speaking, is that what they're speaking about? I can't see the chat. I'm sorry, Kia Beth.
I believe so. And if whoever submitted that, if you need further clarification, please feel free to submit another question. I'm going to bounce through the chat feed. I'm going through Q&A and chat because they're submitting questions in different platforms. If you can please submit it through the Q&A session, that'll be great. I see a question that came through. It says, what about the increased cost of cord testing, Kristen, versus Meconium testing? How did you get directors and finance people on board? That's a good question.
That's a really good question. And so the cost of, and I'm trying to think back, I think that our Meconium screens were around, I want to say $137 each. And I honestly, I can't remember. I'm so sorry, I'm blanking. It was an increased cost moving from Meconium to umbilical cords. And in leadership, we always have to compare, is this the financially responsible thing to do? And then you put that up against, is it the right thing to do for the patient? For our team, I of course had to be forthcoming about what the finance looked like of it and the increased cost. But when I place that next to the benefit to the patient, the benefit to the care team, the improved care to the patient that we could definitively have, some previous experiences that I had had, some previous experiences that I had had from hearing from USDTL, other partners throughout our state. I put together some information about PSU across the nation in our state, also individually, and kind of highlighted the problem is here. I know the problem is here, and I'll have a better opportunity for recognizing the problem, which then leads to being able to reach a solution, or at least a better solution if we move to this. And so for our team, yes, the cost increased, but the ability to better care for our patients drastically outweighed that and made it well worth it. It wasn't a terribly hard sell. And I'd be happy to, and I think that participants, Kia Beth, you can just nod because I know you're on mute. Participants today are from across the nation, is that correct? Okay, so there, and I know Kia Beth, you could offer some resources. There's a perinatal substance use task force here in Indiana that functions through our Indiana Perinatal Quality Improvement Collaborative. And they have done, they've put out some information in cooperation with the Department of Health, just some statistical information about teams in Indiana who have joined in with this. And so I think looking at those results, looking at national results, just looking at NAS and the cost of an infant in the NICU who is going through NAS and who requires pharmacologic treatment, the cost to the community of the infant who does slip through the cracks, who then goes home and is later maybe removed into foster care, God forbid, passes away, or a really untoward outcome for the family and the baby, you can't really put a price tag on that. And so I think just the way that I spoke about it and laid it out for our team worked. And I know that that might not work for all teams, but I mean, I'd be happy to serve as a resource for anybody who's kind of trying to sell this, to state the claim for making this move, because again, for our team, we wouldn't go back to Meconium and urine for anything. Even if the cost, well, and I shouldn't say this to the people at USDTL, but even if the cost tripled, I still think we'd do it because it's worth it for us. I sound schmoozy and emotional about it, but I kind of am, because the care that we can give to our babies is just, it's so much better.
Your passion just comes out, Kristen, and I really admire it. I could really see you're in it for so many reasons, for mom, the neonate, quality of care, and I mean, Just your passion. I love it. There's another,
Sorry, our pediatricians and our neonatologists also, I think that if you have physician buy-in and physician support, that goes such a long way. So I started with our case management team. I then moved to our physicians. And when I put it in front of them, they were all like, duh, of course we're going to do this. And having that physician buy-in and support took us a long way.
Thank you for that, Kristen. Kristen, there's another question here. I think you expanded on this yesterday with me. It says, why store the umbilical cord tissue so long? And I remember you told us a story about the neonate going for their first visit with the pediatrician. Can you kind of dive into that a little more?
Yeah. So when we put either refrigerating the specimen or not refrigerating the specimen side by side, the cost of our refrigerator was like, I want to say $1,200, and we probably could have even purchased a smaller one. But that was the only difference in being able to save the cord longer. So we either could have kept it on a shelving unit or a cabinet unrefrigerated and kept the specimen for 7 days, or we could purchase the refrigerator, $1,200, and keep the specimen for 21 days. Now, admittedly, we have so far since November 1st only had one case where the baby was far enough out from birth that we had to use a specimen that was past a week. But it was, without revealing patient information, it was a critical case. It was a huge save that we still had that cord. What our team agreed to was to follow through this process for about 6 to 10 months, track how many times we use that cord past 7 days, and then decide whether it really is beneficial for us or not. But at this point, again, the only difference is the refrigerator. And I've already purchased it, and it was only $1,200. So for us, it just made sense. But we have only, again, I just to be totally transparent, we have only had one case where the cord would have been thrown away without the refrigerator, and we would have been unable to use it. We have had a handful of cases that were used within that week that we didn't know right up front at delivery. So we've had a lot of saves from that. I don't know if I answered the question. Did I? I did, right?
Yeah, I think so. So I'm going through the chat. Thank you so much for that, Kristen. I have a message from one of our attendees. Her name's Betsy. She is stating this is great information. Betsy, thank you so much for your feedback. We also have here from Melinda. Again, I'm not saying last names due to privacy reasons. Melinda's mentioning our pediatricians became the champions for us, and it made a significant difference to our administration. Kristen, I believe you can relate to that.
Let me try to unmute myself. Sorry. Yeah, and I think that I had said that I took it to our pediatric team and then our neonatology team, and they were sold instantly. Having physician buy-in is key.
Thank you, Kristen. I have here, how far back do the drugs go on the umbilical cord tissue segments? They go back up to the last 20 weeks of pregnancy. Again, if you have any questions, and if you are a current client of ours, and you have questions regarding not seeing a positive on your result, please reach out to our client services department. Colleen Cusack may be the one that may pick up the phone for you, and feel free to connect with client services or someone from our toxicology department. I'm trying to go through here. For Kristen, how long did it take you to implement umbilical cord tissue drug testing with USDTL from point of contact to going live?
Can you, Beth, help me? I think about 3 months, maybe.
Yeah, that seems about right.
3 months. And my back work was really in like billing and coding and where am I going to put the refrigerator and make sure that everything is locked and chain of custody, all of those things, working with FedEx to get the shipments coming and going. But I would say about 3 months. And again, this is just kind of leading us a different direction when we're talking about cost. For anybody who doesn't use this process yet, USDTL provides the FedEx envelope, the FedEx labels, the package that you put it in, all of the paperwork. So we literally just, the kit is provided by USDTL. What we provide is the specimen cup, little saline to rinse it off, and then a tamper seal over top, but not a huge cost to us. All of the shipping and everything is covered in that cost of the test. And USDTL sends us all of those supplies to make sure everything's packaged up. But the answer to the question is about 3 months.
Thank you, Kristen. Kristen, our audience today has some great questions for you. We have another question that came through for you. It says, if you can please share your contact information, they would love to connect with you.
Kia Beth, where can I put that so that it'll go out to people? Or do you just want to respond individually? You can feel free to share my phone number, my email. I'm happy to be a contact for anyone.
Perfect. So I see her name's Sarah. I'll message Sarah after today's event. And if there's anyone else who would like Kristen's contact information, please feel free to email us at newborn@usdtl.com after the event, and we'll be more than glad to share that information. You're very welcome, Sarah. It says, what is the cost to the patient for the test? I could chime in on that one. We do supply the hospital CPT codes for reimbursement to assist with reimbursement. So I believe it will vary on a case-by-case basis. Maybe Kristen could chime into this a little more, but we do supply CPT codes that are helping our clients with reimbursement.
So I think that's probably going to be individualized to each facility and what your negotiated contracts with each payer come through to. I can tell you that we do not receive 100% reimbursement for the tests. We do incur a bit of a cost as a facility. Comparatively to other things that we do, it's minimal, the cost to our facility. But that is part of the back work that I did when preparing for this, is I looked at our previous process of Meconium, the cost to us, the cost to the patient, the overall cost, looked at umbilical cord screening, our payer mix, what our negotiated contracts are, what we expected reimbursement to be, and put them all side by side. So I'm guessing whoever that is, probably your billing and coding department, can kind of help you work through that, what that would look like. And the CPT codes should, Kia Beth can, really email those to you very quickly. And those are what I used to try to look into all of it.
Thank you so much for that, Kristen. I have another question here. I believe it's the last question. I'll make sure I go through the chat just to make sure we're not missing anyone. But this last question says, Kristen, you seem to be so satisfied with USDTL now, but what initially made you choose USDTL?
Again, not paid by USDTL. It's so important because I sound cheesy. I sound like I'm on a commercial for USDTL. What made me choose them? So again, I had some previous experience from several years ago with USDTL. I was aware of the substance use task force here in our state, and I knew that they had done a lot of work with USDTL. And so, and I had Kia Beth's contact information from years and years ago. So what made me choose USDTL? Because they're good? I don't know, because I had already had great experiences with them. I knew a lot of other facilities in our state that had great experiences with USDTL. And I did compare, so the laboratory that we were using for Meconium, I compared the cost with that laboratory and expected turnaround times with that laboratory and cutoff levels with that laboratory with, and I'm trying to not say the names of companies because I don't think that that's right, with a second company that I was familiar with, and the same thing, the cost of their testing, their turnaround times, and their cutoff levels, because those were really the top 3 priorities for us. And then USDTL. USDTL hit the mark in all of them. They had the lowest cost, the fastest turnaround time, and the lowest cutoff levels. That kind of made the decision. There wasn't a reason to go with somebody else. And I have been fully satisfied. Now, that's not to say there are times where things happen. Just recently, just yesterday, I was in contact with Carissa and Kia Beth and client services at USDTL. We had 2 missing specimens. And so we emailed, and I think within an hour had a response from USDTL that said, here are the tracking numbers. We have not received the package. And so actually the problem was living within the shipping process. And so the specimens haven't even made it to USDTL yet. But when you said you sound fully satisfied with USDTL, it's not because the process is completely without issue. There is always something. The patient that admitted substance use and then the cord came back negative, the missing shipment. We have had a couple of turnaround times that have exceeded that 48-ish to 72-hour mark. And we're pretty on top of this. And there's a certain set of newborns that you need that result. You want it quickly. Because you're deciding what to do with that baby. Do I keep the baby admitted for another day to watch? Do I feel comfortable and safe sending that baby home? And so we have messaged USDTL and said, what about this specimen? And they can literally tell us it was received on this day at this time. It moved into testing on this day at this time. We expect it to be complete on this day at this time. So I'm fully satisfied because even when there are glitches, they're taken care of quickly. I don't think I've ever contacted Carissa or Kia Beth or the client services at USDTL and not gotten a response back within an hour.
Thank you so much, Kristen. You know, here at USDTL, we're so proud to mention that we hit our turnaround time at almost 99% of the time every day because we know how important it is. Drug testing is literally all we focus on, and we have a strong emphasis on delivering the results in a timely fashion so that you, the providers, social workers, mom could get the early intervention she needs, the neonate, everybody is a win-win all around. So I'm glad you've experienced a great turnaround time. I have one final question that came through. This one's a really good question. It's they had twins and the twins had 2 different results. Why is that? And that is actually a very common question I've received over the past decade. I've worked with USDTL. When we're looking at twins, it can be different because the way the drugs are metabolized through the placenta, we actually have a scientific article that I can send to you, the individual who submitted this question. It's a little science heavy, but I think it'll be beneficial for you to dive into, but it is normal. Just wanted to stay out there. Kristen, I see your facial expression.
We've not had that here, but it would weird me out if we did. And that would be one of those instances I would ask, what's going on?
Perfect. I'm trying to see if there's any other questions, Kristen. Oh, okay. One more question here. It's can she speak to potential issues with patients testing positive with the lower cutoff levels, and if there are any issues with mom stating no history? So is there any pushback or dissatisfaction from families when there is a family preserved false positive?
With a family, what were the last few words? With a family?
Preserved false positive. I think it's a slight typo. But I'll repeat the question. Can she speak to potential issues with patients testing positive with the lower cutoff levels? And if there are any issues with mom stating no history? You get pushback from mom?
Maybe I think that maybe they're trying to say presumed false positive, meaning, I don't know. Okay, so yes, issues with this. Yeah, I mean, it's a sensitive topic. I think anytime, if you have a mom coming in and admitting substance use and then the baby tests positive, I mean, it's kind of a no-brainer. Everybody's on the same page. Okay, fine. But if you have a mom who has denied substance use and you have a cord that comes through positive, those conversations do get a little bit sticky. I will say that, and I think that our case manager would agree, the large majority of the time, a patient, when presented with actual factual evidence like that. Here is the result of the cord. It tells us that this substance is inside your baby's umbilical cord. It is impossible for a substance to be in your baby's umbilical cord without you having used it. The large majority of the patients will then kind of open up a little bit further. I think most especially when we direct the conversation towards what could potentially happen with NAS for their infant. So I think when we try not to make our conversations about shame on you, you did this awful thing to your baby. We try to really talk about our goal is to make sure that your baby is safe, and that if something is happening, that we can provide you with the resources that you need. Number one, if the mom needs help, we have ways that we can try to help you. Number two, if your baby has been exposed to these substances, there's something called NAS that your baby could go through, could experience, and that could be harmful to your baby. And knowing how to recognize the signs and symptoms of that, and being sure that your infant is treated appropriately if they're going to go through NAS, are absolutely key. And I really do think the majority of the time that'll bring a family around and they'll start to open up some. I'm sitting here and I'm sorry, I'm kind of delaying my response because I'm trying to think of a case when we had a positive on a baby, that a mother didn't admit. I think we've gotten them all to admit. And if we haven't, then it's just a difficult situation. You've got to separate not physically separate, but in your mind, separate the care of the mom from the care of the baby. And then it's a provider decision. How at risk do you think that this infant is? How likely do you think we are to get follow-up? Should we hold the discharge for another 24 hours to watch baby? Is the baby showing us any signs and symptoms of NAS that could lead us to think we should wait a little bit longer? Then you're in a bit of a sticky situation. But I think the way we frame the conversation has usually led to an okay outcome for all. It's a sticky wicket. You could get into, I hear it, and I don't know what the solution is. You have a tough decision to make then.
Kristen, thank you so much for answering that so well. So we have reached our time limit here. We still have a lot of questions that came through that we'll have to answer post this webinar, just to be mindful of everyone's time. And Kristen, I know you have to attend to your unit, so we will go ahead and wrap up. Again, to our audience, your questions will be answered. I'm sorry, but we've reached our time limit. So at this time, I would like to say, Kristen and Colleen, thank you so much for joining us today and sharing your expertise in the field and the recommended solution to eliminate problems with obtaining a viable specimen for early identification on these precious neonates. I would like to thank our audience for joining us today. Please be on the lookout for today's recording. I hope you have a great rest of your day. And with that, how about let us cheers to the next coffee talks.
Thank you for inviting me. Have a great day.
Like and subscribe to our channel to receive notifications about new videos.